Good evening, good afternoon, depending on where you're watching from, ladies and gentlemen. Welcome to today's Facebook Live in partnership with Wound Care Today and HMP Global. This is the last of our 3 events on MASD. So for those who are joining us for the first time, welcome to the adventure. And for those who've been with us since the beginning, thank you so much for your support. We have now had over 1.8 million people engaged with this platform in the last 4 months in 62 countries. So we're all incredibly proud and thank you for being part of it. Tonight's event is called Managing MASD, and our fantastic speakers are with me now. Hi Kim, hi Jan, hi Siobhan, and hi Kris.
Hi.
Hi. Ladies and gentlemen, as you can see, they're all doing the presentation remotely. So if we have any technology problems, please bear with us. And I promise you, we'll get them sorted out as soon as possible. The link for tonight's certificate of attendance that will count towards your revalidation or CME, PD, depending on where you're watching this from, will be made available towards the end of tonight's event. We also have a fantastic MASD support pack that's translated into 7 different languages, so please download that at your pleasure. Slides will be downloadable as well on our website, and anyone who wants to watch the previous events can also find those on our website. As our speakers will agree, the more involved you are, the more engaged you are, the better it is for the event and for them. So please leave comments, let us know where you're watching from, but also ask any questions you think are relevant, and I promise you we'll endeavour to answer as many as possible before the end of tonight's event. Before we start, a massive thank you to our partners, not just for tonight's event, but for the entire MASD project, to our 3M. Without your passion and commitment to independent education, these events simply would not happen and could not happen. So a massive thank you for all your support, for your trust and your hard work from me and the teams at HMP and Wound Care Today. So without further ado, it gives me great pleasure to introduce our first speaker tonight. Over to you, Kim.
Great. Thank you so much, Ed, and thank you as well to HMP for inviting me to speak on this topic. It's something that's really near and dear to my heart. So tonight, what we're going to do, or this afternoon over here in Canada, what we're going to do is go through some of the information to understand the prevention and management strategies for the different clinical manifestations of MASD, and to look at some of the components of structured skincare and hopefully be able to give you some pearls that you can take back to your practice. And more importantly, to understand when, where, and how to use skin cleansing, moisturizing, and various barrier products. So in the first Facebook Live session, for those of you who attended, you learned that moisture plays a key role in damaging the skin barrier by disrupting the structure of the stratum corneum. And I'm going to review that just a little bit so that if you weren't here in the first session, you have a good understanding of the stratum corneum and why we keep talking about it and why we think it's important. And we know that MASD comprises various clinical manifestations, and we're going to speak to 4 of them today and really look at the difference between them and in terms of the type of moisture that induces that damage. And I can't stress enough the fact that early assessment and detection is really the key to prevention. And I think all of us, you're going to hear from the different speakers today around that whole idea of being proactive. That's probably the most important thing that we can do. So if we're looking at the skin, you know, the skin comprises of various layers, as you know, and you hear a lot of people talk about the stratum corneum, which is the absolute outer layer. And we're going to talk about that a bit more, just simply because we need to understand how the epidermis works in order to understand how we can prevent skin breakdown from occurring. So within that outer layer of the epidermis, we can see that we have keratinocytes, and from the stratum cornea, they tend to be dead. They're in the shedding process, but we know that they're predominantly the cell of the epidermis that produces their keratin and forms that epidermal water barrier. And you'll hear a lot, you know, in the literature about transepidermal water loss and the whole idea that we want to make sure that we're not damaging the skin so that we're not losing too much of our moisture. Our melanocytes, this is what offers our protection from damaging effects of radiation in the sun. And then we have our Langerhans cells, which play a huge part in immunity, and our Merkel cells, which is our taste and sensation. So we know that if we damage that outer layer of the skin, there's a lot of ramifications that can happen. So it's really important that we understand this layer in particular. And this is, when we're relating it to moisture damage, it's quite important. And that stratum corneum is the most important layer when we're talking about maintaining our pH-dependent barrier function of the skin. And this is essential for preventing infection and really minimizing water loss. So that outer layer of the stratum corneum, when I'm talking to students, I'm often telling them how it blows my mind of how much is packed into such a thin layer. So we have 15 to 20 layers of fully cornified keratinocytes or keratocytes, and I can never pronounce these words. The top layers are arranged loosely and they undergo scaling and shedding. And this is not a real talk on adhesives, but that's important to keep in mind when you're thinking about how adhesives work and why they loosen over time. In the bottom layer, these cells are closely joined together with desmosomes, and those keratocytes are embedded in the intracellular lipids. And this is important because this is what helps give us our natural moisturizing factors. So when we think about damage to the skin, we lose some of that natural moisturizing. We also have a reduction as we age. So it's important that we protect that layer to make sure that we're not having further damage. So today we're going to look at 4 of the clinical manifestations of MASD. And this includes incontinence-associated dermatitis, intertriginous dermatitis, periwound moisture-associated dermatitis, and peristomal moisture-associated dermatitis. So at this point, I'm going to turn this over to Siobhan, who's going to go into incontinence-associated dermatitis.
Lovely, thank you, Kim, and hello everybody. It's lovely to be here and covering this subject, which is close to all of our hearts. So I'm going to go ahead and cover incontinence-associated dermatitis, or IAD. So I know that some of you may have attended the initial session, and from that, just as a refresher of what IAD actually is, it describes the skin damage associated with exposure to urine, stools, or a combination of both of these in adults. And what we're really looking at is how to identify those risks and implement prevention care planning, because this really is key to prevent that deterioration. And it's really important to remember that IAD can affect the quality of life. It causes a lot of pain and discomfort. Once the skin surface is lost, it's kind of where our nerve endings live. They kind of float around there underneath the surface of the skin. So if you think like when you have a graze or when you have a burn, that sort of experience of pain, it can be described as quite similar for IADs. They're extremely painful. And I think of some of my patients where actually we've got very significant deep tissue injury, such as a category 4 pressure ulcer. We actually have more pain described in these types of injuries than we do in very deep tissue injuries where the nerve endings are kind of gone. And so pain is a really, really important factor with IAD to remember. So being that they're highly preventable, it really is about early identification and our prevention plans that we have in place. Let's look at some of that prevention and management of IAD and what that involves for you as a clinician or a carer. So essentially, we're going to be looking at a continence assessment, and we need to manage their continence to really minimize the risk of that skin becoming in contact with urine, feces, or excessive sweat. And for that, we need to have regular skin assessments in place, and we need to understand what the signs of IAD are. We need a structured skincare plan, and that needs to involve protecting that skin and helping that skin barrier replenish. That often involves using gentle cleansers, and I'll come on a little bit more with cleansing the skin because it's a question we get asked quite a lot. So in terms of the management for an IAD, we have done our thorough assessment. Let's say that we've done our continence promotion, but that person has still gone on to get incontinence dermatitis. The first thing we can look at is actually, can we reverse the causes of the IAD, such as mobility enhancement or using different toileting techniques? In some cases where the continence enhancement is not possible, and you've used the best products that you can get hold of, if you've got access to continence teams within your unit, use them, ask them to come with you and help with that joint assessment, because our continence teams will have a lot of knowledge in terms of that bowel and bladder assessment, and if there's anything we can do to actually try and reverse that incontinence in the first place. Sometimes, and it can be a bit of a grey area, we do use either indwelling catheters or bowel management systems. If the IAD is getting so moderate to severe that it's getting beyond the superficial skin structures and actually causing infection, it may be that we actually need to use a short-term indwelling bowel management system or the indwelling catheter. But both of these have risks that we need to be aware of, such as a catheter-associated urinary tract infection or loss of the bladder plasticity. Or with the bowel management system, quite often they'll be confined to bed because you can't sit up with one of those systems. The other thing we need to be aware of is the kind of creams and the lotions and potions which patients, especially with self-caring or with informal carers, might use, such as these zinc oxide creams that can actually block the continence pads if they're incontinent and wearing a pad. So there's some things to be aware of when it comes to managing, but really it's about the cleansing of the skin and ensuring that it's dry. And when we're looking at cleansing, making sure that we have got a pH balancer cleanser, because the skin acid mantle is about 5.5 as a pH. And as it becomes more alkaline, it loses those building blocks, the skin structure, the epidermis level, the stratum corneum will just start to shed and break down. And that's essentially what you get with superficial skin loss with an IAD, and they're very, very painful. So cleansing and drying, but using a good pH balancer skin cleanser is key. And I think now we're going to hand over to Kris, because there is brilliant global IAD or global IAD. I hope I'm saying that right, Kris, but Kris has actually implemented that within his practice. So handing over to Kris to give us some more information on that.
Thank you, Siobhan. Okay, thank you. I will show you our protocol that we use in our hospital. I work as a clinical nurse specialist in the University Hospitals of Leuven. It's a hospital of about 1,800 beds. So IAD, we know it's the most common problem in healthcare, but also in our hospital, it's a really big problem, or it was a really, really big problem. And we know it can cause a lot of discomfort for the patient. We have no hard numbers by indicator, but what we were seeing the last few years was that we had an increase in wound care consultations for the IAD problems. Other problems that we saw, or difficulties that we notioned in practice, were that there was no optimal prevention and treatment for IAD, but also we have no structured protocol for it. A little or too late recognition of patients at risk, and also there was no or too late start of prevention measures. And when we started, sometimes it was also a too early discontinuation of the prevention measures. And another problem that we saw was there were a lot of old rituals, nurses who wouldn't change some things, some protocols, some new products, because they always believe in the stuff they already use every day. So this was also a very difficult thing. It's also often difficult for clinicians to correctly identify IAD and also to distinguish it from pressure ulcers and other skin conditions such as contact dermatitis or lesions due to infections or perspiration. Which were other reasons why we wanted a new protocol? There were, first of all, new recent innovations in the medical device industry. And there was also the development of a new classification tool, the Globiat, which was also mentioned in previous meetings. The development of a new protocol for treating and preventing of MASD, whilst improving the quality of care for incontinent patients, became a priority in our hospital. So it was, we would say it was very important. And our goal was to implement a new, simplified, evidence-based protocol with a focus on prevention, treatment, and aftercare, and improve comfort for the patient and quality of care. So we we expected a lot of things. So we did how we start the implementation process. The first step was to check the literature and look for guidelines or best practice principles, and even to look what was evidence-based. Next step was to test the new advanced elastomeric skin protectant. We tested it extensively on patients with simple, but also the very complex IID lesions. It was also evaluated on other MASD clinical manifestations as Intertriginous Periwound and Ostomy-associated dermatitis. The case that you see here, it was just one of our cases. It was one of the simple cases. It was a lady of 68 years old with a fractured femur and an infected hematoma on the upper leg. She was treated with intravenous antibiotics which as result a continuous diarrhea, and as a result also she developed an IID. On the first picture on the left, you can see the situation at the beginning. The second picture, you can see the situation just immediately after the application. And on the third picture, you can see after 2 applications, just 4 days later, that the IID was already solved and it was much better, and everything was under control. We also tested it on more complex cases. You can see here 2 of my complex cases where I tested the product. The first case was a boy of 3 years with a Down syndrome, an ear-sprung operation, so a resection of the colon. The IID that you see on the left picture was the situation after 6 months. The boy had already 6 months this terrible IID lesion with an intolerable pain, anxiety, and hysteria. It was a terrible situation for the boy, but also for the mum. So yeah, they tried everything what you can think what is possible, but nothing. There was nothing what was working. So we tried the product, and after, you can see the situation after 2 weeks, which was more comfortable. It was more calm wound, and the situation after 4 weeks where it was almost healed. Another complex case was the lady of 78 years old with a chronic wound discomfort after radiotherapy for the treatment of an anal tumor. This was a situation after 5 months. She developed it also 5 months. It was a big problem also with IID, with a lot of pain. So she had a pain score of 9 on 10. And you can see also the evolution after 2 weeks and after 4 weeks. It was a really incredible evolution that we could, reach with it. So as you can see in the cases, we had very positive results. We were able to heal the simple wounds as well as the complex wounds in a reasonable short period of time. And throughout the implementation of this novel skin protectant, the protocol for MASD was also reviewed, adjusted for evidence-based interventions, and linked to a Globiot classification tool. We also made similar guidelines for the other categories, and moving forward, a hospital awareness campaign and targeted training was put in place. A flyer was developed to make everything comprehensive, and we also adapted the registration forms and developed a complete procedure for the nurses so they know what they had to do to give the good treatment of it. Protocol was called the ABC of MASD. ABC is just a Dutch acronym in care of MASD. The A stands for all-wine points of interest and general cleansing. So Siobhan already mentioned you had to do a good preservation of normal mixture and mixing training. Exchange timely incontinence materials. Always use pH neutral products. Be careful with the use of no need to dry incontinence wipes, because we will use it but will not dry after it, and it can cause some wet environment. Also the general cleaning, we have to wash it, the environment gently, soft cleansing, do not rub while drying, and sometimes we also use a foam to remove the fecal matter more easily. The B stands for border protection of prevention, and when you're connected to the Globiot and you speak about the Globiot 1A, we have seen the intact skin with redness without signs of infection. In that case, we just do after cleaning, we are using the Kevlar wipes, or we use the Kevlar cream 2 times a day, just a little pee There's not a lot of products. And sometimes we also, there's also the need for evaluation of there's a need for a rectal, an indwelling catheter. So, but that's what we had to evaluate every time. We have the C. C stands for curation, with or without infection. When we have no infection, then we can speak about the globiate 1A or 2A, the intact skin with high risk of lesions, or the open lesions. In this situation, we just use the Kevlar Advanced 2 times a week. On extreme situations, it's sometimes 3 times a week, and just as long as the external factor is present. When you have an infection, then mostly is a fungal infection with Candida. Then we see the globiate 1B or 2B, the intact skin with signs of infection, or the lesions with signs of infection. In that situation, we just wash with isopetidine soap. It's a pH neutral soap with a disinfection product. So we use it just as long as there are signs of infection. We cleanse the skin, we dry it softly, and also we use a cream with an antifungal product, so we can also treat the infection. So that is our protocol. So you can see it's very easily. It's not very, very difficult. It's just also with a few products. What were we seeing as this? The result of this protocol was this. It was a successful adoption of the protocol, and also we saw positive evolution in the daily practice. The nurses were more focused on the prevention and also adequate treatment of IID. The campaign and training led to faster detection of risk patients by nurses and also resulted in a quicker start of prevention. In terms of cost benefits, we saw a time saving for nurses. We had not to do every time a lot of changes of the treatment of IID. And we also saw a reduction in the use of the amount of wound edge protectors, paste and ointments. And last but not least, we also saw notable positive effects by using the new advanced elastomeric skin protectant, and the patients reported significantly less pain and increased comfort. So we are very happy with the protocol. We also use it now on a daily basis, and yeah, it works also very good for the moment. So I hope I can give you some inspiration to do some changes in your, or to give you inspiration to do some changes in your protocol when you can make, and how you can make it very easily. Thanks. I will give the word to Kim, who can continue.
Help if I unmuted. You'd think after 2 years I would remember that. Thank you, Kris. So now we're going to switch gears a little bit and talk about intertriginous dermatitis. Now, interestingly, while it is very different in terms of its mechanism and cause from IAD, I think, we need to think about the fact that we don't have a good validated classification system for IAD, and that there's the potential that we could take the Globiad system and that we could alter it and adapt it for classifying ITD. So I think that that's something that as a community, we need to think about doing. ITD is it's an inflammation that occurs and is very more common than people would think. And it's found in skin when we have skin-to-skin contact and friction. So we find it in what we call the intertriginous region. So we will see this under breasts, inframammary region. We'll see it in the axilla area, groin, but really it can occur anywhere where there's a skin fold. And what you need to be aware of as clinicians is that sometimes people especially people who may have lymphedema or who are bariatric, may have skin folds in areas where you wouldn't necessarily think of them having a skin fold. So there could be, for instance, someone with severe lymphedema could have skin folds on their thighs. And if we get sweat that collects or any other fluid that collects there, it can lead to ITD. So what happens is the moisture, and normally it's from perspiration, but sometimes it's from bathing where things aren't dried well enough, or wound fluid that's seeped in, or if someone is incontinent and they've had urine or stool that's run down their leg, or they've been lying in it for a long period of time, they can get it into other folds as well. And what happens is you get this increased friction, or that leads to the skin damage. So it's kind of that skin on skin contact. And often we'll see it complicated by a secondary infection as well. And, you know, I was looking on the chat on the Facebook Live while Kris was talking, and people were talking about, oh, that looks so painful when you're thinking of IAD. Well, when you talk to people who are suffering from ITD, they will complain of severe burning pain and itching that will drive them out of their mind. And I work a lot in aging populations, particularly along people who have dementia. And sometimes we'll see really bad behavioral changes, sometimes aggressive behavior, climbing out of bed, scratching and causing injury. And when we actually investigate a little further, we'll see that they actually have ITD. So it's something to keep in mind as you're caring for individuals. Now, this photo is a patient of mine that was transferred from an aged care home to a acute care facility for care for a medical condition. And they did a great job of taking care of her medically. Unfortunately, her skin was not given the attention it deserved. And she came home back to the aged care facility with probably one of the worst cases of ITD I've seen in my, I won't say how many year career as a nurse. And basically she had satellite lesions. So we knew she had a secondary infection. She was complaining of severe burning and itching. And she had ITD in her bilateral and foraminary regions, both axilla and in her abdominal folds as well. And it really has brought home the point to me that education is the key, not only to caregivers, but also to patients and their loved ones. We need to make sure that we're educating healthcare professionals, anyone who's taking care of someone who's at risk. We need to make sure that we're providing the proper education so they know what to look for and how to prevent it. And I love Kris's prevention program and management program for IAD. I'm thinking we need to take that theory and adopt it for ITD to make sure that we're looking at reducing moisture, minimizing that skin-on-skin friction. And unlike IAD, ITD is actually super easy to prevent because we don't have to, most of the time, we don't have to worry about urine or stool. We're worried about moisture from perspiration. So we may not be able to control the perspiration, but what we can do is to prevent that skin-on-skin contact. We can, if we can't use loose-fitting clothes or moisture-wicking fabrics, what we can do is we can put on some of the barrier creams, you know, such as the Kavlons or the Kavlon Advanced that will allow basically give that extra layer of protection to that stratum cornea. So we need to think about how can we protect those skin folds. And I always tell everybody, get a loose fitting cotton bra onto the women in particularly, just to prevent that skin on skin contact. We need to clean and dry the skin folds using pH balanced cleansers. When we're drying the skin folds, no rubbing. We know that that skin is going to be very sensitive and we don't want to cause further damage. So we pat dry and we want to prevent that secondary infection whenever possible. Itch is a huge problem and it's often indicative of a fungal infection. So we need to monitor closely. We need to be aware, and we need to make sure that we're treating the infection as quickly as possible. And we also know that scratching from that uncontrolled itch, it can lead to infection. It can cause skin damage. And anybody who knows me also knows that I'm a big component around skin tears. And we see a lot of skin tears develop from the uncontrolled itching. The other thing we know, and Siobhan has touched on this as well, is that we want to avoid things like talcs and cornstarch. They'll clump up in the folds and can cause actually little areas of pressure. But as well, there's some literature to show that cornstarch can help proliferate some of that fungal growth. So we certainly don't want to do anything that may potentiate fungal growth. And we also know that there's lots of home remedies that are used, such as various astringents. We see a lot of acetic acid being used or household vinegar, which can be very harsh on the skin as well. And we've all seen as well face cloths, paper towels, all kinds of things. I'm Canadian. I've seen people put duct tape between, in those folded areas to try and keep skin on skin contact from occurring. For those of you who don't know, Canadians love duct tape for some reason. But the most important thing is that we use gentle products. So if someone has uncomplicated intertriginous dermatitis, we can cleanse it with that no rinse pH balance cleansers. Avoid alkaline soaps because we want to keep everything pH balanced. I really like the no rinse skin cleansers and wipes that you can use. Thoroughly dry the skin without excessive friction. So pat it dry. Use those barrier films and creams to protect and moisturize and prevent that skin on skin contact. With complicated ITD, particularly with secondary infection, when we have erosions, this is when you need to look at what's your local policy for the treatment in terms of antimicrobial, antifungal treatments, corticosteroid creams, or compounding of them. And really do that assessment. The picture you're looking at is a patient of mine who had bariatric surgery. She ended up in the intensive care unit, and she was complaining of severe pain and itching in the middle of her back. Unfortunately, it was diagnosed as a pressure injury. They put an occlusive dressing on her, and she said the pain just got worse and worse with that occlusive dressing. She ended up with a cellulitic infection, and it actually went around her entire body, and she ended up with a dehisced abdominal wound. She ended up spending months in intensive care because of the abdominal wound. And on culturing, we found that she was growing a fungal infection in her abdominal wound, and we traced it back to this ITD. So this is a severe, complicated case, but it just to draw home the importance of really listening to your patients and taking care of their skin. So with that, I'm going to hand it back over to Siobhan to talk about peri-wound moisture-associated skin damage. Siobhan?
Thank you, Kim. And I didn't know about duct tape with the Canadians. And it got me thinking we could probably do a whole session based on self-care mechanisms that people use in different cultures and different backgrounds. I think it'd be really fascinating. Okay, so I'm going to go ahead and go through the peri-wound moisture-associated dermatitis. And if any of you are using, looking after patients with any wounds in clinic or in hospital at home, you're going to see this in various different types of wounds. And it's one of those that, again, is a bit misunderstood. So if you came again to the last session, as a refresher, it is an overlooked area, and essentially a peri-wound is the area around any of the wounds that can be affected by wound-related factors or an underlying pathology. But the chronic wound exudate contains very high levels of enzymes that can damage the stratum corneum, and this is corrosive and quite destructive to the surrounding skin. So in terms of prevention and management for this, the first thing we need to do is identify and manage the cause. Where's the fluid coming from? And to do that, we do our holistic wound assessment and skin assessment. You can go back to your time acronym. Any of you that have done wound assessment training, looking at the peri-wound area is part of that under the edge of the acronym. So that is part of our holistic planning when we're looking at these wounds. We look and see if there's high volumes of exudate. It's really important when we prepare the wound bed that controlling edema is absolutely key in our wound care planning. So the peri-wound cleansing, we're removing surface contaminants, bacteria, and any previous dressings and treatments, because quite often with some dressings they stick a bit. We try not to put dressings that are going to stick, but in some cases you can see fibers, so it's really important that we're removing all of those. So to improve the peri-wound area, especially addressing changes and in education, needs to be embedded more. So if you're doing any wound training or education, having the peri-wound maceration incorporated within that education program would be really helpful, because it is absolutely key. In terms of the management, we look at our wound dressing selection in order to optimize the healing, so the tissue bed, but also to minimize further damage. So we're looking for absorbency, really good absorbency to prevent that periwound maceration, but also applying those barrier films around the wound edge to protect those borders. If any of you have been in the bath or gone swimming or been in any fluid for so long, if you come out and think about that crinkly aspect of your fingers that you get when you've been in the water for too long, it's exactly the same for any part of our skin. It can become boggy and macerated. So we need to protect from that moisture. And if any of you are going to have a nice soak in the bath, I'd recommend you put a barrier cream on one hand and not in the other. And then when you get out the bath, have a look at the difference in your hand so you can actually see it in action. A barrier cream is very, very effective to protect periwound area. So having that as part of your care plan in dressings removal, but also in the actual written up care plans is really, really important. So with the skincare, like we've all said, really, it really is education and awareness, both for the patient themselves, but also for the caregiver, whoever that may be that's doing the dressing change. Involve the patients and carers in that care planning. And just remember that that periwound maceration or moisture damage can impair that wound healing. So if you want to avoid any delay in that wound healing, it really needs to be part of your care planning. So I'm now going to hand over to Jan, who's going to go through the peristomal moisture-associated skin dermatitis. Jan?
Great, thank you. So we're going to talk about PMAD if we're going to do all these alphabets, but it's really peristomal moisture-associated dermatitis. And just so we're all on the same page, we're talking about the skin around the stoma. That's the peristomal skin. And when you look at the scope of this issue, you'll see a lot of research recently been done on this, but at least 75% of the patients who have a stoma will end up with peristomal skin problems, most likely peristomal moisture associated damage. So you can see that Dr. Salvadolina had looked at that back in 2013. And I think those of us who practice know that we have quite a bit of problems with peristomal moisture associated dermatitis. When you think about the impact of it, what is the impact? Well, it impairs physical functioning, meaning people with a pouching system who have injury around their skin can't keep their pouch sealed. So they're limited in what they can do. It reduces their quality of life, and there's a higher cost. They're purchasing more and more supplies because they can't get a pouch seal. They may not be even addressing the issue, but just constantly changing the pouching system. So let's think about the challenge, because you've seen the challenges in some of the other moisture-associated skin damages. When we think about it here for our ostomy patients, their challenge is they have skin injury and they need to put a pouching system on top of it. You'll see two typical pouching systems on the bottom of the slide, and they have adhesive backings. That's what holds the pouching on. Now, if we're going to put it on these two patients that have peristomal skin injury, we're going to have problems because the skin has been injured and it's moist. You see right next to the stoma is a very frequent area that we see injury to the skin from moisture because of urine or stool that ends up on the skin instead of into the pouch. But occasionally I'll even see it on some of my patients just a little outside of the stoma, as you can see in the upper right-hand corner slide. So it negatively affects the pouch seal, as I mentioned, and it keeps on going because then they have moist skin, they have a pore seal. They have a pore seal, so there's more moisture. So we have injured skin and we need to get at the bottom of the problem for our patients. So as many of our other speakers have said, we need to determine the etiology. You know, I think as nurses, we look at the skin and we right away say, okay, what am I going to put on it? What is going to be the best thing for my patient? What product should I be pulling out? What I'm suggesting to you is take a deep breath and say, why? Why does this person have the problem with this skin injury? How can I get rid of that problem before I start to treat it? Because we really need to do both of those two things. Now, I know that probably many of you listening are not ostomy nurses, and many times you'll be referring your patients to your ostomy nurse specialist, but keep in mind that he or she is going to do some problem solving. They're going to look at the pouching system and say, what kind of pouching system adhesive should they have? Should it be flat? or should it be convex? And you see examples of these. In the upper left-hand side of the picture, the pictures you see, the stoma is flat. You see it's in really soft skin. This person needs a convex pouching system to get a good seal and to get that stoma to protrude. You see in the bottom picture, bottom left, we see a stoma with protrusion, flat peristomal skin. This person will have no doubt a flat skin barrier. And the other thing is the opening in the skin barrier needs to match the stoma. If they have an oval stoma, they should have an oval opening in their skin barrier. If they have a round stoma, it should be round. And finally, the third thing that we take a look at when we're assessing our patients with stomas, how long do they wear their product? Products are not meant to stay on 7, 8, 9 days. Because they're hydrocolloids, they lose their adhesive gradually over time. And after they're on, say, 4 or 5 days, depending on the moisture of the skin and the moisture of the stool, they can start to erode and allow stool to get underneath. So wear time is something that ostomy nurses will look at as well. So why don't we look at a couple cases, and I can show you some examples. If you take a look at this patient right here, what you'll see is this person had a skin condition that we call pyoderma. Now we have the pyoderma under control. That's a whole nother lecture because pyoderma is quite challenging, but you see the skin ulcer next to the stoma. And you see that hypergranulation tissue that's occurred because there's been so much moisture there. So what we're going to do is we're going to do something to that tissue. We're going to put triamcinolone paste, which is an anti-inflammatory, and we're going to put a thin foam dressing over that area. However, do you see the skin just to the left of the ulcer? What you're seeing there is that moisture-associated skin damage from the moisture. So we're controlling it by trying to get rid of that extra tissue and absorbing it, but now we have to treat the skin. So you see what I mean about look at the etiology, figure out what you're going to do about that, and then move into this. Now let's say, what are we going to do for the skin that's been damaged from the excessive moisture that hopefully we're controlling? I would suggest to you that one of the easiest things to do is to use a skin barrier powder. Again, skin barrier powders are hydrocolloids. They will absorb some moisture. And in this case, what I did was put a lot of powder on, as you see in the middle picture, took something soft, rubbed it in, and brushed off the excess. You could hardly see it on the picture all the way to the right because it's been absorbed. So that's why I just threw another picture in here. You can see that the picture on the far left-hand side shows a minimal amount of surface powder left. It absorbs into the skin. But frequently, even that little bit of powder can be a problem as well. So on this slide, the next step for us was to seal the skin and the powder because it's weepy. Even with the powder, we're not absorbing all of the moisture. And again, remember, if we have that moisture, it's going to interfere with our seal. So we chose to use a cyanoacrylic like the 3M Cavalon Advance that we can put over that because it puts a dry surface, gets that powder sealed so we don't have any powder issues with our pouch seal. And now we can get a seal and we can hopefully get that skin to improve, if not go away. Here's another one of our patients. Actually, this was the first picture that I showed you. And this was a gentleman who came into clinic saying that he could not keep the outside of his pouching system on, that it was wet all the time and it was itchy. And this brings our nursing assessment skills in. So in talking to him, reviewing his medications, how was he feeling, what was new in his life, he told me that he had a lot of dental work. And when he had dental work, he was put on antibiotics and had been on antibiotics for almost 4 weeks. So knowing that and looking at this area, we decided, and you can maybe see a few satellite lesions, but this was pretty advanced when he came to see me, that he had a fungal infection on his skin. And that was very, very moist. And it was not allowing this outer seal of his pouch. The inner seal was pretty good, as you can see that peristomal skin directly around the stoma. Now in the next picture, I'll show you that it's beyond the pouching system, but we knew the etiology now was fungal. So think about what we would do if it's a fungal infection. Well, in this case, what we did were several things, because remember, this was pretty advanced. And I think in the picture on the left, you can now appreciate how that rash was just walking right over to the other side of the abdomen. We are going to use an antifungal powder. We need to seal that with the cyanoacrylic or the 3M Cavalon Advanced. We put him on oral antifungals because remember, this was the entire abdomen from just below the nipple line down that was involved. But I was still worried because this was so moist and so advanced that I wanted to get one more layer. So we used a protective barrier sheet. This is a hydrocolloid. You can see we put it around the stoma. I did not cut the opening to match the stoma because that's not what I was doing. I was not going to protect the skin around the stoma with the barrier sheet. Rather, I was giving the pouching system that you'll see over on the right-hand side a dry surface to stick onto. Now, I think that you'll all laugh when you see this picture, but I learn every day from my patients, and I bet you do too. Suddenly, his wife took out a little fan and she started to hold it up to the skin. She got it. She understood that we had moisture that was our problem here, right? And she was trying to dry out the skin, and she did this several times a day. But again, it was just one piece of that treatment plan, drying out that skin. We needed some topicals that we needed to institute with him as well. And now you can see what it looks like a week later. You can see that that skin looks dramatically better. We're not great yet. And you can still see that we have some issues over on the left-hand side on the post-treatment, but you can also see that it's very flaky and it's starting to heal. We'll continue to protect that skin until we get all of that area healed. And in fact, we did. So it just kind of shows you, will remind you, etiology, and then go after your treatment. So what are the takeaways when you think of peristomal moisture-associated skin damage? Well, I think I've said it a couple times now, but just to remind you, we want to determine the etiology of the skin injury. That's our assessment. That's what we do such a good job of as nurses. We need to correct or at least reduce the etiology. Sometimes it's a pouching system fit. Sometimes there's more to it. We need to think about our skin treatment, providing a dry surface. Think about things like a skin barrier powder, a cyanoacrylic, a liquid skin barrier, in some instances, a hydrocolloid, and we need to think about patient education and support. I work in an outpatient clinic. I know what to do, but if I don't teach my patients what to do, we won't be successful. So we need really always to remember that. Let's kind of think about our conclusions now before we go to questions and answers. And this is what you heard from each speaker today, I think. Comprehensive holistic assessment. It has to be individualized to our patient. It needs to be patient-centered. The patient is part of our team. We need to educate our patients and their families and make sure they know how to do what we were just talking about. When we assess our patient, we need to take a look at those comorbidities and make sure that addressing them is part of our care plan. We can't forget those important basics. What about nutrition? What about hydration? Are we moisturizing? Are we protecting the skin? And then finally, promoting skin health and preventing skin injury should be a priority in all aspects of care. So with that said, I'm going to hand it back over to Kris, and hopefully we'll do some questions and answers.
Thank you, Jan. My name's Ed, but I'm going to forgive you. I've been called a lot worse things.
Oh, who's Kris? Sorry, Kris, whoever you are.
Don't worry at all. As I said, I've been called a lot worse than that. We have been inundated with questions. So everyone watching, thank you for your comments. Thank you for your engagement. Thank you for the questions. So without further ado, guys, do you mind if I crack on really quickly? Because I want to get through as many as I can. I'll try and direct it to the relevant person. If I get that completely wrong, I'm sure you'll work it out between yourselves. So question one for Jan from Ed. Can poor peri-wound management delay wound healing and potentially cause infection?
Are we talking peri-wound, Ed,
Yeah.
or are we talking peristomal?
We're talking peri-wound.
I think I'm going to let the peri-wound people talk about that.
Okay. So I hand that over to Kim.
I can certainly answer that. Anytime you have any kind of damage to the peri-wound area, you're increasing the risk for infection. So when we see peri-wound moisture-associated skin damage, we know that we're at risk of having wound breakdown and increasing the risk for infection. I don't know, Siobhan, if you want to add anything to that.
No, absolutely. I think that's absolutely right. And it really is important to have that as part of your general assessment when you're doing wounds, be it leg ulcers or whatever it is. But yeah, absolutely needs to be part of our holistic assessment planning.
And document it. That's important. You have to document what the skin looks like so that people from dressing change to dressing change know what that peri-wound skin looked like. So if there's a change, we can address it. Far too often, we're great at documenting the wound, but we forget about documenting what the peri-wound skin looks like.
Jan, while we're on that, can you answer that as a peristomal answer as well? Because I think that would be interesting to our listeners as well.
Sure. I think that anytime we help manage a patient with ostomy, we should be looking at two things. We should be looking at the stoma itself, and we should be understanding how it's functioning, what's coming out of the stoma, what's the frequency, what's the volume, what's the consistency. And the reason I point that out to you is our patients with a lot of liquid output have more problems with moisture-associated skin damage around a stoma. And the second piece that we need to do is we need to look at the peristomal skin. We need to look at the integrity. We need to look for any openings or injuries in it. And we need to look at that skin in several positions. We need to see them sitting and laying down, and sitting is the most critical. And the reason I point that out is that's how we're going to determine the shape of the skin barrier, at least one of the determinants. So looking at both the stoma and its function and the skin integrity, and in at least two positions.
Brilliant, thank you. So next question for Kris. What made the protocol work in your hospital, and what were the difficulties?
Thank you. It's always not that simple. We also did a small study of the implementation process, and we looked which were the barriers and the facilitators that nurses experienced during the implementation application of the protocol. What we saw was, first of all, it's very important to assess and diagnose IID correctly, and also to distinguish it from pressure ulcer. That's a very important thing. Nurses had also to have sufficient knowledge about IID. Education and continuous coaching are very important. So bedside coaching made that the protocol is applied much easier. Our most important facilitators that we saw was that it was also the very important that you see a positive effect and result for the patient. When it's less painful, it's more comfortable for the patient. Yeah, always nurses will use the protocol more easy. Also, the positive attitude and the good communication of the head nurse, who is responsible for the communication. When he believe in the protocol, it's also much easier. Also, the immediate presence of materials on the ward. When you have materials on the ward and you can use it immediately, yeah, then you can apply it more quickly and more easily. So that's also very important. Easy use of products, but also the easy use of the protocol. Almost 70% of our nurses found that it was direct added value. So yeah, they believe in it, and then yeah, they can use the protocol also very easily. The barriers that we saw was sometimes there was some confusing concerning the use of different products. That's not always that easy, but therefore it's very important that you use in your protocol not a lot of products. Just make it easy, not a lot of products, but with a few products you can also do a lot of things. Also, when there was an immediate absence on the ward, it was sometimes difficult to use the protocol very good. A strange thing was also a positive barrier was that when the lack of IID, when you have not a lot of IID on your ward, yeah, then it's good naturally when you have not a lot of IID, but yeah, that was also some difficult because they have not always that experience and the knowledge of the IID. And a specific problem was sometimes also how to use advanced skin protectant correctly. You had the Kevlar Advanced, you had to try it long enough that the product not stick anymore. It is an invisible product, but it's not easy for nurses. And yeah, nurses always want to supply something, they want to do something. And that's always some difficult for nurses that, yeah, you cannot see what you are doing. And yeah, so that were what we have seen, but yeah, it worked perfectly now. And yeah, we are very happy with it.
Kris, thank you. So next one, Siobhan, where can bowel management systems be used?
So it's usually acute, hospital, critical care, intensive care, that sort of place, because in the community, they're quite difficult to manage. They need to be, again, holistically assessed. We don't want to go straight to bowel management systems or indwelling catheters. It's really kind of a last case scenario for where it's becoming very moderate to severe. And so we tend to use it more. I work in a critical care hospital, so we tend to use it in our critical care wards. And again, with bowel management system, you can't sit in a chair. with indwelling catheters, you're going to potentially lose bladder spasticity. So it really is a case of kind of last chance saloon to try and protect that area. So it would be, in my experience, it would be critical care units where that person could be monitored on a 24-hour basis.
Fantastic, thank you. Next question. Sorry, I'm rushing through them. I'm keen to get through as many as possible before our hour's up. So Kim, this is for you, from Martine. Thank you, Martine. Can athlete's foot powder for fungal infection be used in the same principle as ordinary talc?
So that's actually a very great question that we get asked a lot. And my party line is that that would be off-label use, and I can't condone that. However, you may want to talk to your nurse practitioner or family physician to really find out, if they're okay with you using it in that manner. We see it used frequently. The big thing is in Canada, at least, we have to be very careful that we use products on label. So that would be an off-label use of that product.
Okay, thank you. Next one from Peral for Kris. Are there any side effects for inappropriate or excessive use of barrier products?
Can you say it again? Sorry.
Are there any side effects?
Yeah.
For inappropriate or excessive use of barrier products?
Oh, I don't know. It's a difficult question. Can Jan or
I can help with that one.
Okay.
So there are potential harms with anything. The products have to be used appropriately. So if you use too much of a barrier product, say along with an incontinent brief, you can clog the pores of the brief and then you won't get good absorption. If you use too much as well, you can actually give too much moisture. If we use some of the cyanacrylate products like the Kavlon Advanced, you need to make sure that you're keeping the folds, whatever you're using it, well apart, and that you're letting it dry very well, because it is a type of an adhesive. So you need to make sure that you're using the products appropriately.
And I'd just jump in here to say, I see some of my ostomy patients use powder all the time because they saw me use it to help them heal their skin, and they think of it as a preventative. And in fact, it isn't. So it's really keen to teach patients how to say, okay, now it's healed. I only use that in the presence of moisture.
Just briefly, can I say as well about those zinc oxide creams? Please be warned of them, because I could see in the comments as well that quite a few people have said about using them. And I remember 20 years ago when I was a carer, I used them. We were told, that was a good thing. So unless I had two white shiny buttocks, I didn't think I did a good job as a carer, but actually we now know that's blocking the pad. So, we know the kind of creams that we're talking about, hopefully those thick white pasty creams, like avoid them like the plague, because they actually block these pads and cause quite a lot of problems in practice. So just wanted to get that in there.
Thank you, guys. So 2 more to go. So Jan, this is for you. When the skin is injured around the stoma, how often does the patient need to change the pouching system?
Yeah, that is a critical decision point, because leaving it on too long means some of that moisture is going to loosen the seal. So when you think about average wear time for a person with a stoma, there's only really one research study out there, and a really descriptive study that said average wear time is about 4 days. But once you put moisture underneath there, even when you have a treatment plan, I usually tell my patients, let's cut that wear time down. Let's get it down to about 2 days. The reason I say that is because I want them to get it off. I want them to see if we address the problem. Is there stool or urine still underneath? Did we fix the etiology? And even with the best of pouching system and the best of treatment, there's still going to be some residual moisture. I always tell my patients and the staff, when you take a pouching system off, you look at the back to see if there's any moisture that's underneath it. So I teach that to my patients. If there's moisture underneath it, the pouching system was worn too long. So it's somewhat individual, but just think of those principles.
Brilliant, thank you. So last question from Gail. Kim, I'm going to put it your way. I think I might have got that right. As a foot health practitioner, what should we be aware of with regards to moisture-associated skin damage?
Oh, I'm so glad someone asked that question. So, we talked about the different types of MASD. We actually didn't speak to trench foot today. which is a whole other category of moisture-associated skin damage, which occurs on the feet. And so we need to be well aware, particularly in our homeless populations, where they may not be able to change out of wet footwear, that moisture-associated skin damage is a problem. We need to look at what kind of barriers, creams can we use on their feet to provide some protection. We need to lots of education around changing socks frequently, having dry shoes. Now, that's easier said than done in many populations. And we have a problem here in Canada in the wintertime where people will get their feet wet and then they'll freeze, and then they get snow in their boots, whatever, their feet freeze, and then we get frostbite on top of that moisture-associated skin damage. It becomes a real problem. So we actually have campaigns where we have people donate socks and footwear to the emergency departments and to the outreach clinics, so that people can come and get fresh footwear as needed. But the most important thing is, can you get good moisturizing and protective barrier film creams on? I use a lot of Kevlar cream because of that silicone barrier it puts on. So we try to get that onto the feet, and then, you know, getting those dry socks and shoes. And education is a huge component, but it becomes a huge challenge when you're dealing with a population that may or may not have mental health issues and may not be able to fully comprehend the damage they're doing to their feet.
Kim, thank you. In fact, everyone, thank you. I hope you get a chance to watch this back, because we don't get to see the comments and the questions coming through. But I've had a quick look, and some very kind words being used and some amazing engagement. So to our audience, thank you so much. And to our speakers, guys, thank you so much. So that concludes tonight's session. Please download the resource pack. The link for the certificate of attendance should be available now on the screen. A massive thank you from me. Again, to our speakers, to 3M, our partners, a huge thank you from me and all the team. You've been fantastic from the beginning of this project, and your support's massively appreciated. To the teams at Mole, to Wound Care Today, HMP, a big thank you from me. And last but not least, to our audience. You continue to inspire all of us. What you do is truly incredible on a day-to-day basis, especially in the period of crisis we've had over the last few years. Thank you for everything. Stay safe, stay strong, and we'll see you very soon. Thank you so much. Goodbye.